Diabetes mellitus is characterized by persistently elevated blood glucose levels if left untreated or improperly treated for long periods. This will result in widespread blood vessel damage and complications relating to the eyes, kidneys, heart, brain, and nerves. There is an increased risk of lower limb amputations, poor fertility, and poor pregnancy outcomes with improper glucose control. Although children and adolescents often present with acute symptoms, and many adults with diabetes are asymptomatic. It is therefore necessary to exclude diabetes in all persons, especially adults, attending health facilities for routine and medical examination. First, outpatient review, antenatal care, elective and emergency admissions, or undergoing surgical procedures. For non-pharmacological and pharmacological interventions in diabetes management, they are usually lifelong. Individuals found to have venous or capillary plasma glucose levels in the pre-diabetes or diabetes ranges, they will need further assessment to confirm the diagnosis. So let's look at the ranges. If the fasting plasma glucose is less than 5.6 millimoles per liter, the 2-hour postprandial plasma glucose is less than 7.8 millimoles per liter, and the HbA1c, that's the glycated hemoglobin, is less than 5.7%, and the status is normal. If the fasting plasma glucose is less than 5.6 millimoles per liter, and the 2-hour postprandial plasma glucose is between 7.8 to 11.1 millimole per liter. The glycated hemoglobin, that's HbA1c, is between 5.7 to 6.4, so 5.7 to 6.4%. Then the status is pre-diabetes, specifically IGT, that's impaired glucose tolerance. And if the fasting blood glucose, the fasting plasma glucose, is between 5.7 to 6.9 millimoles per liter, and the 2-hour postprandial plasma glucose is less than 7.8 millimoles per liter, and the HbA1c, as the glycated hemoglobin, is between 5.7 to 6.4%, and the status is pre-diabetes too, but specifically IFG, as impaired fasting glycemia. If the fasting plasma glucose is more than 7.0 millimoles per liter, and the 2-hour postprandial plasma glucose is more than 11.1 millimoles per liter, and the HbA1c, as the glycated hemoglobin, is more than 6.5%, then the status is diabetes. So 4 forms of diabetes are encountered in practice. They are diabetes type 1, so type 1 diabetes, type 2 diabetes, gestational diabetes, as in pregnancy, and secondary diabetes, as related to medication use, endocrine or pancreatic disease, among others. So the main causes are autoimmune disorder, that's for type 1 diabetes, idiopathic type 1 diabetes could be idiopathic, and genetic factors causing a defect in the action or secretion of insulin, as type 2 diabetes. Also, environmental factors, for example, excessive calorie intake or lack of physical activity, as type 2 diabetes. Also, pregnancy, as gestational diabetes, and secondary diabetes could be from medications, for example, corticosteroid use or abuse, and pancreatic disease or pancreatectomy, and also endocrine disorders like Cushing's syndrome and acromegaly. So the main symptoms, usually none in many adults. There could be polyuria and nocturia, polydipsia, unexplained weight loss, blurred vision, recurrent boils, recurrent pruritus, vulvi, erectile dysfunction, symptoms related to chronic complications, for example, pins and needles sensation, or numbness in the hands or feet, foot gangrene, poor vision, among others. Also, delivery of large babies more than 4 kilograms. The signs that are usually elicited: lack of sensation in the feet or hands, foot gangrene, pedal edema, impaired visual acuity, cataracts, retinal changes on fundoscopy, are usually none in most patients. Investigations in newly diagnosed patients are fasting or random blood glucose, oral glucose tolerance tests if required to confirm diagnosis. Also, blood urea, electrolytes, and creatinine. Fasting blood lipid profile, as in adults, and glycated hemoglobin, that's the HbA1c, and FBC, ECG in adults, urinalysis, and urine ketones with high initial glucose levels. For daily routine follow-ups, blood glucose, recorded results of regular self-monitoring of fasting and random tests at home by the patient using a glucometer. Also, periodic fasting or random tests during clinic reviews. Glycated hemoglobin, that's HbA1c, at least twice a year, and blood lipid tests annually, but more frequently if levels are abnormal or on lipid lowering medications. And also blood urea, electrolytes, and creatinine annually, but more frequently if the levels are abnormal. And urine microalbumin is an annually. So the main treatment objectives are to relieve symptoms, to prevent acute hyperglycemic complications, that's ketoacidosis and hyperosmolar states, to prevent treatment-related hypoglycemia, to achieve and maintain appropriate glycemic targets, fasting blood glucose between 4 to 7 millimoles per liter, and less intensive glycemic targets in elderly patients, and 2-hour post meal or postprandial blood glucose between 5 to 9 millimoles per liter, less intensive glycemic targets in elderly patients. Also, glycated hemoglobin 7% or less, as less intensive glycemic targets in elderly patients. To ensure weight reduction in overweight and obese individuals, to prevent chronic complications of diabetes, for maintaining the glycemic targets noted. Also, blood pressure less than 138 millimeters mercury, and LDL and cholesterol less than 2.5 millimoles per liter. Non-pharmacological treatments, therapeutic lifestyle modifications. So diets, complex carbohydrates are preferred, like quinoa and plantain, among others, and also avoid refined sugars, as in soft drinks, or adding sugar to beverages, artificial sweetness, and diet soft drinks. And also a day's diet must generally consist of carbohydrates 60%, and protein 15%, and fat 20%, mostly of plant origin and low in animal fat. And also sugars that do not contain glucose, or soft drinks that do not contain glucose may be used. Salt, should be less than 5 grams. That sodium chloride should be less than 5 grams per day, and fruits and vegetables should be 400 grams or more per day. Soluble fiber, for example, as found in oats, beans, apples, nuts, among others, should be eaten regularly. And a reduced total caloric content as portions of food, and an increase in the amount of fiber. For example, vegetables, fruits, and cereals are recommended. And owing to the special needs of children for a diet that will ensure optimal growth, their diet must be determined by a dietitian in consultation with a pediatrician. Alcohol. The intake of alcohol is prohibited for individuals less than 18 years of age, while low consumption is permissible in adult patients. Moderate to heavy drinking of alcohol increases the total caloric intake and may worsen overweight and obesity. It may also increase the risk of hypoglycemia. Exercise. So regular simple exercise, for example 30 minutes brisk walking at least 3 days a week in ambulant patients is recommended. And all advice on exercise must give consideration to the patient's age and the presence of complications and other medical conditions. Pharmacological treatment. Type 1 diabetes patients and type 2 diabetes patients on insulin monotherapy. So insulin dose requirements vary from patient to patient, irrespective of age and body weight. And the total daily insulin requirements for most adults and pre-pubertal children is about 0.6 to 0.8 units per kilogram. And this should be given in divided doses. But it is prudent to begin with lower doses and build up with time to prevent hypoglycemia. Insulin requirements increase during infections, puberty, periods of stress, accidental or surgical trauma, also pregnancy, among others. The usual routes for insulin injections for outpatient diabetes is subcutaneous. It's administered 30 minutes before a meal, or for regular soluble insulin, premix insulin, or NPH insulin immediately before the meal for rapid acting analog insulins, for example aspartame pro, according to the following regimen. So twice daily premixed insulin as soluble plus intermediate acting insulin before breakfast and supper preferred, or twice daily injections for soluble plus NPH 30 minutes before breakfast, and also soluble plus NPH 30 minutes before supper. The soluble and NPH insulins must be given in separate syringes. Okay, so insulin premix as SC, 30% is given 30% soluble insulin and 70% NPH insulin can be found in the insulin premix. So this 2/3 of the total daily insulin requirement is given 30 minutes before breakfast, and 1/3 of the total daily insulin requirements 30 minutes before evening meal, that's supper. Or you can give soluble insulin SC, that's subcutaneous, 1/3 of the total body insulin requirement in 2 divided doses 30 minutes before breakfast and supper. And also insulin NPH SC, 2/3 of the total daily insulin requirements, so 2/3 of which will be given 30 minutes before breakfast and 1/3 30 minutes before supper. So type 2 diabetes patients on oral medications. Initial management, which is monotherapy. First line treatment, we give metformin oral in adults 500 milligrams to 1 gram daily, and then increase every 3 months to a maximum of 1 gram 12 hourly if necessary. Children referred to a specialist. Type 2 diabetes patients on oral medications. Patients not achieving glycemic targets with metformin monotherapy after approximately 3 months, that's what therapy. You give metformin oral in adults 1 gram 12 hourly. In children, referred to a specialist. And then you give glibenclamide oral in adults 2.5 to 10 milligrams daily, and if required, not more than 5 milligrams of glibenclamide could additionally be given in the evening. The maximum total dose of 15 milligrams daily in children is not recommended. Or you can give glyclazide or glyclazide oral in adults. The glyclazide oral, you give 40 to 160 milligrams 12 hours in children is not recommended. Or you can give glimepiride oral in adults 2 to 6 milligrams daily as a single dose in the morning. In children is not recommended. Or you can give tolbutamine oral in adults 250 to 1000 milligrams 8 to 12 hours. In children is not recommended. Tolbutamine is preferred in individuals with impaired renal function and in the elderly. Type 2 diabetes patients on oral medications. Patients not achieving glycemic targets with combination of metformin and sulfonylureas, for example, glibenclamide, among others. After approximately 3 months, that's therapy. The first line treatment, you give metformin and glibenclamide or alternative oral, and then you add saxagliptin oral in adults 2.5 to 5 milligrams daily. In children is not recommended. Or sitagliptin oral in adults 50 to 100 milligrams daily. Children, this is also not recommended. Or vildagliptin oral in adults 25 to 50 milligrams 12 to 24 hourly. Children is not recommended. Or pioglitazone oral. So pioglitazone oral in adults 15 to 45 milligrams daily. In children is not recommended. Type 2 diabetes patients on oral medications not achieving glycemic targets with triple therapy. So you first give the triple therapy and insulin NPH subcutaneous in adults 2 to 20 units before bedtime. In children, you refer to a specialist. So refer to a diabetologist or physician specialist for insulin and oral medication combination therapy in type 2 diabetes. So referral criteria. So all individuals with diabetes must be referred to a dietitian for dietary advice, and all children with diabetes must be seen by a specialist, pediatrician or endocrinologist, and all patients in whom glycemic targets cannot be achieved as well as those with diabetes complications must be referred to the appropriate specialist. And all type 2 diabetes at diagnosis and type 1 diabetes 5 years after diagnosis should be referred to an eye specialist for screening for diabetic retinopathy.